So I'm going to just take a moment or two just to have just a little bit of context for things. And I'm starting out with probably the first time this has ever been at a cancer center seminar, but this is an astronomical clock from the old town in Prague, Czechoslovakia. And I bring this up here because this was commissioned in about 1410. It was meant to be a clock, okay? But it's very complex. On the one hand, it does have the hands of time. It has a lot of things on here that have to do with the stage, with the months of the year, the states of the moon. Once an hour, biblical figures come out, including death, come dancing out at the top here. And it's a highly complicated mechanical thing. In the same way, when I saw this last year, thought a little bit about some of the nuts and bolts of what we try to do in cancer prevention. And when I came here 20 years ago, the leadership here asked for me to try and work in translational prevention, in clinical trials. And because people like George Adams and because Lee Wattenberg and Steve Hecht had worked in these things, I thought that there was a very good atmosphere and infrastructure to be able to do this. But when I came here, I found out a lot of things that make all of this work extremely difficult, because a small amount of it is the fun discovery science that we like. But the rest of it is what to do to actually get things into patients, to try and do interventions, to try and come up with the holy grail, which is more prevention drugs in the field of cancer. And I came up with a lot of things where it's like, okay, I knew that for certain kind of things that I wanted to advance, I'd have to come up with $75,000 or $100,000 that no one has in their back pocket at an institution to try and go through the regulatory stuff. Oops. A lot of this is drug reuse, so it's not as enticing for study sections and whatnot, but are we going to start a new drug company for some of these things that we wanted to do? What are we going to do? Could we convince NCI reviewers the novelty that every other day aspirin is fantastic compared to the new signal transduction pathway to be able to fund it as an R award? Do we have all the extra capacity and intermediate endpoints, pharmacokinetics, pharmacodynamics, multi-omics? Do we have all of those things to be able to execute such an award? And do we also have an adequate population size for primary, secondary populations to generate a couple of accruals a month? And on top of that, most of us that try and do this stuff on the clinical side are seeing 20 or 2,500 outpatients a year, and then I add about 300 surgeries to that. So early on, the saving grace of all of this is the sort of stuff that highly dedicated people at the Division of Cancer Prevention of the NCI have worked on for a decade and a half. They gave up on certain kind of funding mechanisms with R01 funding because it's hard to do this stuff from one institution. It's hard to get the accruals. So they came up with these NCI consortium. They've had these NCI contracting programs, the PREVENT program. And what it all takes care of is the FDA regulations. A lot of this can be drug reuse, and they're okay with that because at the end of the day, they want to get these into patients. Expert capacity for all these things that can be lacking at an institution. They have their own clinical research organization. It's an NCI peer-reviewed mechanism. And they always have the protocol offices and audits and centralized IRB. And with that, I want to introduce Eva. Eva Szabo was originally a college student at Yale. She went to Duke University for her medical degree and then came to the NCI to work with Mike Beerer in AP1, transduction of C-Jun and related proteins into U937 cells and some other things along those lines. But along that way, when she was a junior investigator, she became very interested in preclinical prevention and cell differentiation, not much different from some of the theories that were going on with how you can exploit retinoids in aerodigestive cancer. And from there, she went on to be the program leader and branch chief for aerodigestive prevention. And there's this core group of passionate individuals in prevention, many of whom are at the NCI, and work very hard on the fact that only tiny amounts of this are discovery science. But at the end of the day, we're most excited about the discovery science, but also about getting agents into people that can be new preventions. And they're not supported by pharma, typically, these kind of initiatives, because pharmaceutical companies don't want to invent prevention drugs. So it's all those difficulties that Eva thinks about every day to try and really advance the field with her and her other program leaders there and the people in the Prevent program. So it's with that I want to welcome her here today and thank her for coming.
All right, so thank you, Frank. And okay, so this is working, but I guess I have to look this way. So if I look a little bit stiff, it's so I get this. So thank you very much for that introduction and for the opportunity to talk to you about cancer prevention. I will focus more on the progress, but of course mention the challenges. And what I'm really going to be talking about mainly is the early phase clinical agent development and the program that I oversee at the NCI. So I think we all know, whereas when we treat patients in the clinic, we think of a person who's got this lesion on the CT scan that we can either cut out, treat with whatever number of therapies that we have, but it's a process. It's not a thing, and cancer is something that occurs over a long period of time, and that's really the focus of cancer prevention. We know that there are genetic factors and genomic abnormalities that occur over time as this abnormal cell progresses onto an invasive cancer. And there are environmental factors that impact on this. Tobacco carcinogenesis, of course, is a major focus of my life. There are random factors that lead to these abnormalities. But the fact that this is such a long process with multiple stages and with people whom you can identify as being at higher risk, this is what results in the concept of cancer prevention. And the rationale is very simple. We're still not curing metastatic cancers. Yes, everybody's excited about immunotherapy, as am I, but by and large, if you have a stage 4 cancer, solid cancer, chances are you're going to die from it. And this is very well reflected on the progress we've made in lung cancer. You've heard about the decrease in lung cancer deaths, very exciting, but a 2% decrease is nothing. The US lung cancer survival is about 18% for all comers. It's over 200,000 cases a year. And it's really not that much better than it was 50, 60, 70 years ago. We also know that cancer is preventable. We have clinical trials that show, trying to make this better. Okay, I think that works better. We have clinical trials, well done, phase 3, randomized trials in breast cancer that show that you can reduce the incidence, reduce the risk of subsequent breast cancers. And of course, multiple animal models, starting with the work of Lee Wattenberg, who is well known to this community and is one of my idols. We know that we can do it in the clinic. So how do we get this to people so that on a societal level, we can really reduce cancer incidence and all the morbidity and mortality that goes with it? Well, it all boils down to the fact that there is this long preclinical phase, and we should be able to actually interfere with the process. So just a couple of overarching thoughts. Cancer prevention is quite different from cancer treatment. When you know you're going to die, if you don't do something radical, you will take a lot of risks and accept a lot of toxicities. In cancer prevention, it's a little bit different because people are at risk, but the majority, even of the high-risk people, do not get cancer, and certainly not in a short time frame. So to move concepts forward, you really have to have a very solid efficacy indicator. We look at mechanistic ideas. Is it still? This seems like it has gone dead. How about this? Okay, so well, thank you. All right, that works better, I think, because I can lean forward. So we look at efficacy data. When you know what results in the development of a cancer, you can intervene. HPV and cervical cancer, best example of that. It's a causal relationship. If you prevent infection, you will prevent the cancer. For most other cancers, it's not near the causes and effects are not nearly as well identified. So we also go to preclinical models, animal studies. We look at observational data. We look at evidence from prior clinical trials. The fact that tamoxifen led to decreased incidence of contralateral breast cancers was excellent data, which eventually led to tamoxifen as a preventive agent. But the flip side of that is the toxicity, and it's the toxicity at the doses you're going to use. So a lot of cancer prevention has flown from epidemiological studies on nutritional agents, for instance. But when you switch over to a pharmacological dose, you need to make sure that the side effects are not different from what was eaten in the diet. And you have to develop these agents very rigorously as drugs with all the preclinical toxicology that you need, and also with the understanding that a lot of these exposures are going to be long-term and not short-term. And we've all been burned by the fact that drugs that you take short-term that are FDA approved, I'm thinking of rofecoxib, COX-2 inhibitor, which was approved for rheumatological indications, and in a very well done cancer prevention trial that showed that there was a decreased risk or decreased new adenomas, colorectal adenomas, the cardiovascular risk became clear and the drug was taken off the market. So now you can argue that this is a good thing, that people who would use rofecoxib would have been taking it long term. So we simply unmasked something that the FDA development process did not adequately identify. But the point is that if you're going to do preventive interventions, you need to know the long-term risks and the severe risks, as opposed, in addition to the short-term toxicities that we normally focus on in agent development. We need to focus on cohorts that are likely to respond, but not suffer the toxicity. So the higher the risk, the more side effects you're willing to accept, but you also need to understand the pharmacogenomics and how drugs are metabolized. So the bottom line is that in moving forward with cancer prevention, we really need to think about the whole person. We tend to focus on, for instance, for lung cancer prevention, we focus on smokers and want to assess their real risk of lung cancer, but they also have cardiovascular disease. And they may have colorectal polyps, and if they're women, they're at risk for breast cancer. And so interventions that have potential benefits across a variety of chronic diseases, cancer and other, are the ones that are going to be prioritized. So let me get the challenges out of the way, and I promise not to whine too much. But this is a difficult field. Everybody in the 1990s thought, oh, cancer treatment is so hard, but surely prevention is easy. Well, in many respects, prevention is harder because you're trying to prevent something that hasn't occurred, and it's only going to occur in a small portion of the population you're studying in the short period of time that you can study. So it's sort of like preventing a terrorist attack. You only know if you failed because it happened. But all the work that's going on to actually prevent it, you never know about it, right? So we have sort of the same challenge. And the real challenge is that we do not understand the early phases of carcinogenesis across these many target organs well at all. Yes, smoking causes lung cancer, but there are many different forms of lung cancer. We're now recognizing that these various genomic abnormalities, the driver mutations that result in different types of disease, even though it may look the same under the microscope, these diseases have different natural history. Why would one type of intervention prevent all these different pathways? That's a huge challenge. And so we really do need to go back and study that pre-malignant process longitudinally, not just as a cross-sectional, in a cross-sectional way, but to follow these lesions, or at least the whole area at risk over time. And that's what the Precancer Atlas is starting in a baby step sort of way to assess. And the challenge is even deeper than that, because there are multiple ways to get to cancer, and there are different time frames for individuals to get to that. So not only do they have a variety of pathways to go down to get an invasive cancer, but what's happening in the person who's sitting in the clinic in front of me right now? Is this a person who's going to get a KRAS-dependent lung cancer? Is it a person in whom BRAF is mutated? You know, these are all different ways of getting to cancer, and the temporal component differs. Some people get their cancer after 30 years of smoking. Some people get it after 15 or 45. So these are all challenges to a difficult process. Another challenge, big challenge, these are the two H's, heterogeneity, right? Between and within populations. There is spatial divergence of how different lesions, all of which are initiated, actually result in cancer. And different processes are driving these different lesions, even within the same individual. For instance, we know that in tobacco-driven cancers, if you look from an evolutionary perspective, the mutational spectrum of those initial driver mutations is very much a tobacco-driven mutational spectrum. But as these go on, if you look at the metastases and over time, you have other processes that are driving the abnormalities. The APOBEC-associated mutational spectrum takes over during the later phases of carcinogenesis. So even in these tobacco-induced cancers, there are different processes that are leading to the ultimate invasive and metastatic phenotype. And of course, you have to take into account the host response. Different people have different ways of fixing of detoxifying carcinogens, different abilities to mount an immune response. And so all of these challenges make the process of cancer prevention, makes it science of cancer prevention multidisciplinary and difficult to do. And we tend to go with the latest interesting technology that we can do. And so I just want to remind people of what I thought was a fascinating study looking at the mutational burden in normal eyelid skin. So the eyelid, of course, is exposed to sun. It has, if you look at the number of mutations, it's huge. The same driver mutations that you find in skin cancers and in other cancers, but how many eyelid cancers have any of us seen? It's a site that does not get cancer, despite having all the mutational damage that comes with living in this world. So it's not just about the mutations. It's a much more complex process. And that, of course, impacts on how we're going to try to develop agents for cancer prevention. So that's enough for the challenges. Let's move on to where we are right now and where we hope that we will be doing. And so this is a shout out to the program that I oversee at NCI. It's actually the whole drug development process that Frank referred to at the Division of Cancer Prevention. And we have programs that begin with identifying agents preclinically, getting them to the point of actually getting into people up to the IND phase. That's the PREVENT program and others within the preclinical agent development group. We have a phase 3 program, that's the NCORE, and I believe that you have a robust NCORE program here as well. But in between is this valley of death that people like to think about in terms of drug development, which is how do you get those interesting ideas, those pathway-driven concepts to phase 3? How do you get enough indication of efficacy and safety to really justify a phase 3 program, phase 3 trial, because those phase 3 trials are large, they're expensive, they involve many people and a long period of time. And of course, the resources are tremendous. And so that's what my program oversees, which are the early phase clinical trials. It's a small program. It's one of the few areas where you can get funding for phase 2 studies, which are so important before going to phase 3. And the types of things that we focus on these days, which I will highlight, are immunoprevention, a new field. Obviously, with the advent of immunotherapy for cancer treatment, the question becomes, can we actually harness the immune system to prevent cancer, perhaps at a point where the immune system is more effective before you have that whole immunosuppressive program that the body puts in place. We have also focused very much on how to optimize that risk benefit. There are agents, and I'll show you the tamoxifen saga, which are very effective and yet are not being used. How can we make those kinds of agents more acceptable? And of course, Frank referred to repurposing drugs that we know what they're like. We know their side effect profile. Can we repurpose them for cancer prevention? And I'll talk about a couple of these. So let me start with immunoprevention, which is frankly a pretty new field for us as well as for the community. And really, in the setting of cancer prevention, it refers to two main areas. Vaccines against infectious agents, which are responsible for 20 to 30% of all cancers, so not an insignificant number, and vaccines against tumor-associated antigens. And so our current portfolio, and I will go into this a little bit, really has become, I would say, fairly robust given the short period of time that we've been doing this in this research area. We have focused on cervical cancer and have several studies looking at more, well, we hope to soon start a study of a more protective HPV vaccine using this RG1 VLP, which was developed by the PREVENT program, as well as therapeutics of intraepithelial neoplasia in the setting of HPV, so cervical intraepithelial neoplasia with several different agents. And we've also been developing agents such as the MUC1 vaccine, which I will now talk about, as well as a multipeptide vaccine for breast cancer. This is Nora Decis's WOCVAC vaccine and a PSA vaccine. So let's talk a little bit about MUC1. MUC1 is a tumor-associated antigen that has been around for quite a while. It is really expressed in most adenocarcinomas, so quite heavily in the colon and the lung, for that matter. And what's particularly appealing about this as a target for cancer prevention is that it is differentially glycosylated. It's a very heavily glycosylated molecule that when it comes to the cancerous state, and even in precancers, the glycosylation is much less, thereby exposing peptide antigens that can serve as the basis for a robust immune response. And it is highly expressed in many premalignancies, including lung, including colon. So Olya Finn at the University of Pittsburgh has been really the main, I think she cloned MUC1 when she was still at Duke, but has been the main developer of a vaccine. And we had the good fortune of partnering with her to perform a study of a MUC1 vaccine in patients with newly diagnosed advanced colorectal adenomas. Now, there will be an abstract on this at ACR, giving more data than what I'm giving now. But the bottom line is that the trial was in 40 to 70-year-old people who had recently had a colorectal adenoma resected, as is normal care. They were given MUC1 vaccine 3 times and then a booster after a year. The primary endpoint was change in the IgG titers after the 3 vaccinations compared to pre-treatment. And the secondary endpoints are the durability of the immune response. And because people who have a colorectal adenoma resected will have another colonoscopy at 3 to 5 years, we will look at adenoma recurrence. And that's the data that will be presented at ACR. So the primary endpoint was reached. It's been presented at prior ACR meetings. Bottom line, 102 people randomized, And the twofold immune response increase in the IgG was found in about 25% of people who had been vaccinated versus 0% placebo. So not as robust a response as one would like. And so the question really becomes, can you get a better response before you go on to a late stage study that will actually look at the real efficacy endpoint, which is adenomas? I will give a teaser that the adenoma data are interesting and they will be presented. So look forward to seeing that data. So what are we going to do to develop this vaccine further? Should we drop it if only 25% of people have a response? Actually, about a third of people had a slightly lower response, which is a 1.5-fold tighter increase. Is that enough? Don't know. Remains to be determined. But there are a lot of studies ongoing to try to figure out how to get a better immune response. So even in the setting of colorectal adenomas, which is early in colorectal carcinomatosis, you already are not able to mount a good response, or a lot of the people who have this level of adenoma are not able to mount a good response. And so trying to decrease that immunosuppressive state, which is perhaps part of what gets you to colorectal carcinogenesis, is really the focus of further studies. And there's studies ongoing, especially combining the vaccine with aspirin, because PGE2, which aspirin helps block the formation of, is very immunosuppressive. And so obviously more early work needs to be done before this moves forward to phase 3. Let me turn to examples of how we're trying to optimize the risk-benefit ratio and altered by various ways, the topical or local regional approach, as well as through alternative dosing regimens. So we all know that tamoxifen is highly effective in reducing incidence of invasive breast cancer and even non-invasive breast cancer. It is actually approved for risk reduction. Tamoxifen, raloxifene, other SERMs, aromatase inhibitors. But people don't take it. Healthy women don't take it for a variety of reasons. Part of it is bad press, part of it is side effects, part of it is increase in endometrial cancers, which can be managed, but nevertheless, that's a scary thing. So how can we do better than tamoxifen? And that's the rationale for trying to go regionally, topical approaches to breast cancer prevention. And that's an interesting saga, very much championed by Seema Khan at Northwestern University, whom we, again, had the pleasure of working with over the years. Turns out, and I did not know this, the breast is really a glorified skin structure. It is embryologically derived from the skin. It has a very well-developed internal lymphatic circulation, and drugs that are applied to the breast, to the skin, actually get into the breast, deep inside. And that is the rationale for trying to take tamoxifen or tamoxifen metabolites, which we know is effective systemically, trying to approach it topically without getting all those systemic side effects, which result in the hot flashes, et cetera, and the endometrial toxicities. And so 4-hydroxytamoxifen is an agent, which is a major tamoxifen metabolite. Dr. Khan did an initial study in our previous iteration of our phase 2 clinical trials program, where she compared topical 4-hydroxytamoxifen with oral tamoxifen in women who had DCIS, so non-invasive breast cancer in a pre-surgical setting. This is a great study for so many reasons. So only 27 people were treated. Why only 27? Because there was no more drug to be had. Because the drug expired, the company was not interested, and so poof, there went the rest of the study. However, in those 27 people, it was shown that proliferation in the breast, in the abnormal tissue, was about the same, was decreased in about the same way in oral versus topical groups. The tissue concentrations of this metabolite deep in the breast were about the same. And the endocrine biomarkers, systemic biomarkers, were significantly reduced in the topical treatment compared to the oral treatment. There was not a difference in hot flashes, but there was a difference in other biomarkers. Move forward 5 years, and the drug supply has been reestablished. There is another company, that is actually two companies that are interested in this. And so we now have two new studies. One is really the continuation to get the rest of the patients on study for this pre-surgical DCIS cohort, so that we can get more definitive information on its efficacy and the side effects. But perhaps even more important is a phase 2b randomized placebo-controlled trial of women with mammographically dense breasts who are going to get the drug now for a whole year in between their yearly mammograms, with the endpoint being breast density. And this is actually an endpoint that FDA has said would be acceptable for drug approval. So this phase 2, we hope, will move forward to a phase 3. And this trial is about 3/4 accrued, so it's going well. It's perhaps the agent that is the most mature in terms of moving forward to phase 3. There are other topical studies ongoing. There is an anti-progestin study that was just finished, again, a pre-surgical approach with the results pending. There is a different tamoxifen metabolite that is being used, endoxifen. And there is a retinoid, bixaritine, which has potential to be used in an ER-negative fashion. All these other drugs are all for ER-positive breast cancers. This has potential for ER-negative breast cancer, and so the phase 1 is currently ongoing. A different way to minimize toxicity is to dose the drugs in a different fashion. So this is work from my colleague Ron Lubet at NCI and collaborators in the academic community. Looking at a mouse carcinogenesis model that develops breast cancer, the MNU carcinogenesis model, looking at differential efficacy in different ways of dosing erlotinib of all agents. And what you see here is that if you don't give any treatment, animals with tumors, the animals develop tumors 100% after a certain amount of time. But whether you give erlotinib in a daily fashion, or 2 days on, 2 days off, or once weekly at a higher dose, you essentially get the same level of efficacy. And what's interesting about this is if you look at the pharmacokinetics, erlotinib disappears, even at the high dose, it disappears from the circulation fairly quickly. But the pharmacodynamic effect, this is phosphorylation of ERKs, is very strong for a lengthy period of time. So this gives a rationale for giving once weekly dosing or various on-off types of regimens. And these kinds of data have been replicated in colorectal models, animal models, in lung models. And so we have a number of studies ongoing that are trying to model this now in people using agents that we think, that we know in some cases, and we think in other cases may be efficacious. We have a breast cancer study using aromatase inhibitor, exemestane, given daily versus 3 times a week versus weekly. It's a pre-surgical study that we're doing the biomarker analysis even as we speak. We've tried to model this in lung cancer, and I'll show you that data in a little bit, looking at a readout of tobacco-related gene expression in a surrogate tissue, the nasal epithelium, and we've also done it in breast cancer. It takes a long time to get the results of studies for prevention because it takes a long time to get them up and going, to totally accrue, and then, of course, to do the biomarker analysis. And so maybe next year we'll have the results of certainly the first and the third of these. Okay, let me move on to a slightly different topic, which is repurposing old drugs for cancer prevention. Because as Frank mentioned, if you're trying to understand toxicity in the setting of cancer prevention, you're really looking at long-term toxicity, and it's not the ideal platform for developing completely new drugs. You really want to know that the drugs are safe and tolerable, and so moving from drugs that whose long-term safety we know to the cancer preventive setting is certainly a way to skip a painful and lengthy part of drug development. So let me tell you what we've been doing with metformin. Metformin has been in the news. I think the interest has perhaps peaked and started to wane a little bit. But a few years ago, there was a lot of interest because of a whole body of literature suggesting that cancer incidence and mortality are reduced in people with diabetes who take metformin as opposed to other agents. And there's certainly a lot of mechanistic data that would support that. But that literature is actually quite mixed and is affected by multiple biases and confounders. And relative risk is decreased if you look across all cancer sites, with about a 30% decrease in cancer incidence. But once you start to correct for things such as body mass index, which is high in many people who take metformin because they have diabetes, obesity-induced adult onset diabetes, and time-related biases. So, you're comparing people who are in the early phases of their diabetes compared to those who take, let's say, insulin or other agents who've already gone through metformin and are now in the late phase of their diabetes. That level of relative risk is less and less impressive. And if you look across I don't show the data here, if you look at various cancer sites, you can't pick up a good signal for most cancer sites, including obesity-related cancers. And so how does one move forward in this field? Well, NIH, NIDDK has a diabetes prevention program, which looked at people with pre-diabetes who were treated either with metformin or an exercise, lifestyle intervention, and actually initially with thiazolidinedione, although that arm was stopped after the drug showed some liver toxicity. And there's long-term follow-up of this population, and so we'll be able to pick up a signal for all cancers, not for individual cancers. In the meantime, we've started to assess the effect of metformin on the target tissue in various organs. Excuse me, there was a study of Barrett's esophagus, which showed no effect on any kind of downstream biomarkers or proliferation. There was a study in prostate cancer looking at the effect of metformin on prostate cancer. And this was an underpowered study, but at least it showed that the metformin gets into the prostate at high levels, although there was no effect on any kind of biomarkers. And just recently, there was a study looking at colorectal aberrant crypt foci, which are precursors even before adenomas to colorectal cancer. And again, we could not pick up any kind of signal. On the other hand, we did look in the setting of oral leukoplakia, and this is a study that Frank was also involved in. And this is work that really stems from Silvio Gutkind, who was initially at NIH and now is at UC San Diego, where he developed a very robust body of evidence suggesting that perhaps in head and neck cancer, metformin could be effective. And because head and neck cancer is not that common, the large studies and the meta-analyses really wouldn't pick up a signal of metformin users versus other agent use in the diabetic population. And so the rationale for using metformin for oral cancer prevention is, I think, quite robust. The mTOR pathway, which metformin impacts, is activated in the vast majority of head and neck cancers and in premalignancies. And a very nice study looking at an animal model showed both decrease in tumor multiplicity, profound decrease, as well as low-grade and high-grade dysplasias in this animal model after metformin use. And so we performed a small phase 2 study, which enrolled 22 participants, all of whom had oral leukoplakia. And so this is a busy slide, but I'll get right to the chase. The clinical response, which is the size of these premalignant lesions after 3 months of treatment, was decreased in slightly fewer than 20% of people, 18%, and a very similar about the same number progressed. So this doesn't suggest a clinical benefit. But what was intriguing was that 59% of participants had a histologic response. So the level of abnormality on histologic analysis was substantially decreased in almost 2/3, a little more than half of participants. This is a short study, only 3 months. It is an uncontrolled study. There is a natural regression rate of oral leukoplakia. So these are interesting data that are certainly not enough to push you to a phase 3 trial, but perhaps are enough to suggest that we should look at it in a more controlled manner, plus or minus another agent. So what to do with metformin across the board? Clearly insufficient data to move forward to phase 3, as honestly we were being pushed to do in the past 3 or 4 years. But we need to understand what's happening in the oral cancer setting a little bit better. We're sequencing those lesions. We're looking at the salivary microbiome, variety of secondary endpoint biomarkers. And we need to continue to figure out, who do we really want to target? Is it everybody who's got a lesion in the mouth? Is it some people? Clearly, there are data emerging for past 2 decades, honestly, showing that the more genetically abnormal the oral leukoplakia lesion is, the more likely the person is to develop oral cancer over time. And frankly, that data are more striking for the non-smokers. So if you have a lesion that has loss of heterozygosity and you're a non-smoker, you're at higher risk of developing cancer than if you're a smoker, although that risk is pretty high as well. So risk assessment has to go hand in hand with preventive interventions. I'm going to spend a little bit of time, because this is University of Minnesota, because I still mourn the loss of Lee Wattenberg, as I think a lot of people here do. I am going to spend a little bit of time talking about the work that has led us to our approach for lung cancer prevention, which is actually my main day job, as opposed to what I've been talking about in our program. And a lot of this work really flows from the model systems that Dr. Wattenberg established, especially his animal work showing the role of steroids in urodigestive cancer prevention, which led to studies that we did with Stephen Lamb in British Columbia on testing these ideas in a human laboratory setting. And so the work of Lee Wattenberg established that oral and, more importantly, inhaled steroids can very effectively prevent cancer in animal models, really more so for adenomas. And when he eventually went back, and others went back to look at the squamous carcinogenesis model, those agents were not effective. But for many years, we had no way to study lung adenocarcinoma formation. Now we actually do. So the way we translate these kinds of preclinical data are to either look at the bronchial epithelium, looking at bronchial dysplasia, which is where squamous carcinomas arise, or to look at CT-detected lung nodules, which look at adenocarcinoma formation imperfectly, which is the peripheral lung. And it's really the second way is what the animal studies of Dr. Wattenberg really should be translated. However, we didn't have that data years ago, so the way we moved forward with Stephen Lamb was to look at bronchial dysplasia using an inhaled steroid, budesonide, with people who were screened initially by sputum, then by bronchoscopy, and those with dysplasia were either given inhaled budesonide or placebo for 6 months and then underwent bronchoscopy a second time. And this was a negative study. The complete response rate in bronchial dysplasia, subsequent dysplasias, was the same, whether people got budesonide or placebo. And the progressive disease rate was also pretty similar, 40 to 50%. And in fact, subsequently, the animal studies that looked at squamous carcinogenesis showed the same effect. So this was, to a large extent, capacity and clinical trial development. What was interesting is that when this study was done, it was in the era that CT screening was just starting to occur and was being tested. There was a significant, albeit small, rate of resolution of people who had who had CT-detected lung nodules in those who took budesonide versus placebo. And so that led us to our first study of how do you look at the peripheral lung where we would expect budesonide to work from the preclinical data. And that was to look at CT-detected lung nodules. So persistent lung nodules that were detected on screening CT. This is a trial that was done by Giulia Veronesi and colleagues in Europe and Italy, who had a CT screening trial ongoing. And so 202 participants who had any kind of persistent nodules were treated for a year before their next screening CT to look at the rate of nodule shrinkage. Again, it was capacity building, trying to figure out how to do these trials the right way. About 70% of nodules were solid. They did not change over a year at all. About 30% were non-solid or part solid. And these nodules had a small, albeit non-significant, decrease in size after budesonide. And if you, so there was 1 year of treatment. If you follow these people over time, actually the budesonide arm became statistically significant in terms of shrinkage. This is a small amount of shrinkage, a few millimeters. The study was nowhere near powered enough to look at lung cancer incidence. And because it is a rather small amount of shrinkage, and because we still have questions about how well budesonide gets into the periphery, which is what this is looking at, we have chosen not to follow this up. But what we did learn is that the solid nodules are not the ones to look at. I mean, these are solid nodules that are not thought to be cancer because they're small, they're persistent, and in fact, you know, living in this world, you have all kinds of abnormalities in your chest, all of us. So how do we move forward? So we're trying to figure out, first of all, how to study the peripheral lung and what to study it with. And so you may recall the Sir Peter Rothwell meta-analysis from now quite a number of years ago, showing that if you look at people who were treated with aspirin, any dose, for cardiovascular disease prevention, that over time, starting with 5 years and out, there's about a 20% decrease in cancer mortality. So not just cancer incidence or cancer mortality, all cancers. And you can't see this, but this is, it's really adenocarcinomas driven to a large extent by colorectal cancer, but also to a smaller extent by esophageal and lung adenocarcinoma formation. And as I said, you can't see this, but whereas the curves diverge at 5 years for all cancers and for colorectal cancer, that's this one here, for lung cancer, they really diverge quite early. And so by 5 years, you have a statistically significant decrease, whereas for colorectal cancer, you really need to get out to 10 years to get this statistically significant decrease. And it is not squamous carcinoma, it's only adenocarcinoma. And so we put this to the trial with the following hypothesis. So, and I'm going to actually leave out many of my slides, and so I apologize about that. But in any case, so formation of lung adenocarcinoma from the normal lung to these lesions called atypical adenomatous hyperplasia, all the way to invasive cancer. By 5 years, you're dead from your lung cancer. That means that by 2 to 3 years, you had your early stage lung cancer. And so within a year of starting aspirin, you should have your premalignancy that you can actually pick up in the lung, and it should be modulable because it takes a long time of smoking to actually go from just the exposure to premalignancy to invasive cancer to death. And so that was our thinking, and we focused on these premalignant lesions, these non-solid nodules, which I showed you just recently in the Budesonide study. This is what they look like. And these lesions are about 25% of the time are AAHs, so these premalignancies. And if you follow them over time, at least once they're big enough to be resected, about 6 or 7% of them become cancer, whether it's localized or actually invasive. And so we put together 2 studies. One is, again, with the same group in Italy, looking this time at CT-detected lung nodules, which are only non-solid, so either pure ground glass or part solid, looking at low-dose aspirin over a year of time. And this study is finished and should be reporting in the next 6 to 12 months. We also ask, well, if aspirin works, can we pick up efficacy at an earlier stage? So can we put together a biomarker study that would look at how aspirin might work? Now, how might it work? Well, one way would be to undo the damage from tobacco. And so can we look at a gene expression signature that actually reflects tobacco damage? And so this is where the work of Avi Spira at Boston University became very important, because he has shown that the histologically normal epithelium, bronchial epithelium, reflects damage, whether there's a adjacent lung cancer or even whether there's just smoking or an adjacent pre-neoplasia. And this damage actually is reflected throughout the aerodigestive field, including the nasal epithelium. And so many of the gene expression changes can be picked up through swabbing the nasal epithelium. And so we asked the question, 2 questions, actually maybe 3 questions altogether, which is aspirin, which looks like it may reduce lung cancer deaths, can you pick up effects on this tobacco-induced damage in a surrogate tissue, the nasal epithelium? And also, can you sequence this in an intermittent fashion? So in other words, do you have to give continuous aspirin, or can you just do intermittent aspirin? Again, trying to get at a more tolerable dose. And so the first of these studies really randomized continuous versus intermittent aspirin, looking at gene expression changes. And the second companion study, looking at the same patient population, added a lipoxygenase inhibitor to aspirin, and then this is where the placebo arm is. And we only have data from this first study. This one has finished accrual and is being analyzed. And to make a long story short, I will say that continuous and intermittent aspirin were pretty similar in terms of blocking prostaglandin synthesis. This is urinary PGEM, but really neither one showed any kind of change on the smoking caused gene expression, the changes in the nasal epithelium. Could be because low dose aspirin is too low dose. Could be that's not how it works. It doesn't block the effects of smoking. It's something else later on. But what we're trying to get at is, how do you do the studies? Can we do a study without having to go down into the lung to do bronchoscopies, invasive bronchoscopies? And so this kind of approach, and perhaps it's not the tobacco gene signature, perhaps it's some other gene signature that we need to focus on. This is all building capacity. And that's how we're trying to move forward with lung cancer prevention and how to do the studies, because that's where we are. I am going to skip just about everything else next year or some other year, and just get to the bottom line. So what do we need to do to move forward? It's back to the biology. Understand the biology, understand the natural history of these lesions. The pre-cancer atlas is really important. Who progresses, who doesn't, why do they progress versus not? We need to target those processes that are deregulated over all different types of pathways of carcinogenesis. So not the mutations, but what causes mutations, whether they be BRAF, KRAS, EGFR, you name it. And of course, trying to harness the immune response. We need to understand who are the people who are at risk, and we need to do better with the clinical trials. And so we're now sampling the whole field in an omics fashion, trying to understand those deregulated pathways and what happens over a short time frame, which will help us to get to efficacious agents earlier. Obviously, we need to focus on molecularly homogeneous populations, not just at risk, but at risk in the same fashion. And of course, for cancer prevention, as always, it's the entire person. It's not one disease that they are at risk at, because we are at risk for many different diseases, chronic diseases, and that's what we need to focus. And so that's pretty much it. There are opportunities. It's a long process. We should be able to figure out how to cut it short. And that's what our work is all about. And I hope that many of you will join us. And these are many people who've been very important in getting us to this point. So I'm happy to stick around for some questions. I know it's 9 o'clock already.
Thank you. That was great. I used to teach biochemistry to dental students. And so I know that oral leukoplakia is treated with retinoic acid. Is that still, or no?
Yeah, I mean, there were promising studies that showed that it would be a good way to prevent progression to cancer. But the phase 3, so retinoids are pretty difficult to tolerate.
Yeah.
And so the phase 3 studies actually use lower doses, which were tolerable, and there was no effect on head and neck cancer. So it's really not used at all.
Okay.
There's no intervention other than following and or cutting out. That is currently the state of the art.
Okay. All right. That answers my question without actually asking my question. Thank you.
Okay.
Thank you very much. It was really exciting to see all the progress and the good studies. And then you had this slide, I don't remember what it was, where you said we can cure 20%, but we didn't follow up because it wasn't enough.
So what's enough?
That sounds great. I mean, when you cure 20% of lung cancer patients from 18 to 38, that would be awesome.
But that's not what that study showed. So what that study showed was that there was a decrease. Oh, you mean for aspirin? So the 20% decrease in death was for aspirin. The study that we did, which was inhaled budesonide, wasn't really looking at lung cancer. per se. It was looking at size of these small nodules, which is a surrogate, and don't know how good a surrogate, because a lot of those nodules are not going to go on to cancer. So if all those little nodules had disappeared, I say, yep, I see that there's effect. I'm happy with it. 20% is a numbers game. So you really need more to push it forward. It depends on how good the surrogate is.
I had a question. So you alluded to it at the end of your talk, but I was curious your opinion. What is the role of epigenetic mechanisms in chemoprevention in general?
I think that there's probably a lot there that we don't understand. And epigenetic approaches, just like all other approaches, just need to go through that drug development pathway. So agents that interfere with or change the epigenetic milieu need to be addressed the same way as any others, with preclinical models and then early phase clinical trials. Absolutely. It is an approach that I think a lot of people, that several different labs are taking. So nothing against it.
Hi, this was great. Is there any recent progress in the prevention of pancreatic cancer as well?
Yeah, so that's a really tough one. There are genetic cohorts, turns out, right? People who have BRCA mutations, for instance, CDK4. So there are groups that have higher risk that you could actually target. And so I think there is a fair amount of preclinical data being done, and pancreatic cancer is one of those recalcitrant cancers that Congress has mandated that we study together with small cell. But the problem that I have with it is, who do you target, right? Because pancreatic cancer, while devastating, is still relatively rare. And so bringing that to anything other than a genetic cohort, which is a very small number of people, it's going to be hard to study. So if we get good hints of efficacy from the preclinical studies and from understanding the process, particularly in the genetic cohorts, then by all means, I think that there are groups that we could go to. But as a general strategy, it's going to be hard to figure out that you have an effective agent.
I agree, thank you.
I wonder if you can say a word about your branch and the NCI's view of natural products. In my kind of clinical experience, most people don't want to take drugs, but they're more than happy to take CoQ10 or reishi mushroom or what. For some reason, there's a connection between drugs bad and natural products good. And you also get beyond the idea that you have to have a drug sponsor if it really works in prevention. So I just wondered what you guys are thinking.
So we are very supportive of approaches that include a pathway that is similar to drug development. So if you can get a purified compound so that you know what you're getting, it's the same each time. So in other words, not just a food grade compound, but one that has a company behind it that purifies it, then by all means, we're happy to do it. We do have some agents that we've studied. One of them is sulforaphane that we're doing with Julie Baumann in Arizona. And so doing it in a drug type development process, I think is fine. The problem with many natural compounds is that once they're purified, there's also a fair degree of off-target or multiple target effects. And so it has the same problems as drugs. But yes, it may be an easier sell than drugs. Wouldn't be for me.
Thank you very much, Dr. Szabo.